and welcome to another episode of Medicare Matters with Mackenzie. Today we're going to be talking about Medicare Advantage, which is it's a type of coverage that you can get to help cover additional things that original Medicare may not be able to. So before we get started talking about that, we're going to do a little bit of an overview. So Part A and Part B, they are what's known as original Medicare. So they come directly from the federal government. Part A is your hospital insurance, Part B is your medical. Part A covers inpatient hospitalization, room and board, skilled nursing facility, home health care, hospice, and blood. There is a premium for Part A, but as long as you have the work history, 10 years, 40 quarters, you should be good to go. If you yourself don't have that work history, then you can use your spouse's. I'm not going to go into all these numbers, but just as a refresher, with your inpatient room and board, you have different benefit periods and different amounts that you have to pay during those times. Same with skilled nursing facility, home health care, hospice, and blood. They all have associated out-of-pocket costs with them. Now, Part B is your medical. So this comes into play anytime you go see your primary care doctor, a specialist, if you have a surgery, anything like that. Durable medical equipment, so think wheelchair, oxygen, and then your preventive services. So your wellness, Medicare wellness exam, cardiovascular screening, diabetic screenings, things like that. And with Part B, that monthly premium is $185, even annual deductible of $257, and then it's an 80/20 after that. You can pay more than that for Part B for your premium based on your income from 2 years prior, from your gross income. And so what doesn't original Medicare cover? So it doesn't cover your prescription drugs, out-of-country care, routine eye care, hearing aids, dental, and long-term care. So if you want any of those services to be covered, you're going to have to look at additional insurance, which is where we come to Medicare Advantage. So Medicare Advantage are offered by private companies, and they cover your prescriptions, vision, dental, and hearing in varying amounts. You have a network of doctors, specialists, and hospitals, and they're rated by what are called star ratings. So star ratings, it takes about 3 years or so for a plan for them to gather enough data to be able to give a star rating. So there's a medical and then a prescription. So then the both are averaged together to give you the overall star rating. Star ratings are how a Medicare Advantage plan is rated. So there's a medical and a prescription star rating, and they're averaged together to give you the overall. What goes into it are surveys, how well doctors like using it, ease of claims, how well the plans help its members adhere to prescription medications, its coverages, things like that. And there are different types of Medicare Advantage plans. So these are going to be more similar to your employer coverage. But what's different is typically with employer coverage, you have a deductible, right? You have an individual and a family deductible. And then once you meet those, for example, for the hospital, you have to pay a percentage of the total cost after that. So with Medicare Advantage, it is a bit different because you're not really going to have all those huge deductibles and everything. So when you're thinking about this, when I'm explaining this, keep that in mind that it is similar to an employer insurance. So you can get these with or without prescription drugs. They can come in HMOs, which is a health maintenance organization. With an HMO, you have to have a primary care and you must get referrals to see specialists. So all Medicare Advantage plans are, the areas of coverage are by county. So with an HMO, you have to stay within that service area, the specific counties listed on the plan to receive care. Now, if you're outside of that, or if you're out of the country, those are covered. Emergencies, life-threatening are always going to be covered at the in-network rate. Another option is a PPO. So with PPOs, you don't have to have a primary care doctor. You don't need referrals for specialists. And these also do have the service area, right? The different counties, sometimes it can be state. But with this, you have access to providers that accept Medicare, but don't exactly outright take the carrier or your specific plan. So for an example, if you are let's say Colorado, because Colorado's it's an easy thing here. So if you're traveling in Colorado and you have a life-threatening emergency and the closest hospital isn't in-network. So once you go to that hospital, it will be covered at the in-network rate because it's an emergency. If at some point you are deemed stable enough to be transferred to the nearest in-network facility, and then you choose to stay at the hospital that you're currently at, the out-of-network facility, then that's when the hospital can say, okay, now we're going to start charging you the out-of-network rate. Now, I say Colorado because 3 hours in Colorado is different than 3 hours in the Midwest, right? It's mountainy, and so we could kind of argue that, hey, and it's not a guarantee, but hey, the nearest in-network hospital is so far away, and it's just not possible, not ideal to have you transferred. And so we can look at trying to see if it would get covered in-network. You also have point of service plans. We have these. A lot of the times they're attached with HMOs. You'll see like an HMO POS after, and the POS actually works for the dental. So that means point of service, which means you can go in network or you can go out of network. Like I said, it's mostly geared toward the dental. In other areas throughout the United States, there are just point of service plans. They're not as common. Then you have your special needs plans. So within these, there's HMOs and PPOs, but you can have one for Medicare and Medicaid, what we call dual. And then you have chronic care plans, like for people who have diabetes or cardiovascular or congestive heart failure. You can also have them, it's not listed here, but institutional plans. So if you are in a nursing home, there are plans that could potentially be a better option for you. I'm not saying that they are. It's always wise to look at what your options are and compare and contrast, but those are another type of plan that is available. Now, with or without prescription coverage, the only time that you should consider getting a Medicare Advantage plan without it is if you get your medications from the VA or a different way that doesn't actually use your plan. Mostly just with the VA, because if you do not have a form of creditable prescription insurance, meaning it meets the Medicare standard, then you open yourself to some penalties, and we'll go over that next. So the Part D penalty only kicks in if you have no form of creditable coverage. That means as good as Medicare's. So if you're working after 65, as long as your health plan, a good rule of thumb is if it covers more than 20 employees, then it's typically good to go. However, I still recommend that you talk to HR and ask whether or not you are required to have Medicare or if the plan is actually creditable. And so a good way to find that out is also if you just get the tax form at the end of the year showing that you were covered. The penalty is 1% of the national base premium. So this year it's $36.78. So you get a percentage of that. So like 36 cents a month for the entire year. And then the next year we'll have a different amount. So whenever you finally do sign up for that prescription insurance, you will have to pay the penalty amount, so the amount of time that you didn't have any coverage, each month for the rest of your life. So it's really easy to avoid. I mean, I have some of my clients have said, I'm never going to take medications. I don't want that coverage. At some point, they'll come back and say, hey, I need to take this medication. Can I get some coverage? And then they're stuck with this penalty for the rest of their life. And so that's not a situation that we want to be in, especially if it's very avoidable. So how much will you pay for your medications? So there's different tiers. Tier 1 is generic, Tier 2 is your preferred generics, Tier 3 is preferred brand name, and also generics that are treated like a brand name. So a common example, and this may be true in some areas, not true in all areas. For example, like albuterol. Albuterol is a generic, it's an inhaler, but it's typically treated as a Tier 3, a brand name, just because of the cost. Tier 4 is your non-preferred brand name, and Tier 5 is your specialty. So depending on what your income is, what you pay for your medications is going to be a little bit different. So within the Part D coverage stages, this year was actually pretty unique. So they finally got rid of the donut hole, which they've been telling us for years they would get rid of. But starting this year in 2025, the Part D coverage stages changed. So your stage 1 is your deductible period. So it's $590. Now, not every single plan is going to have this. That's just the most that they're going to have. And so, it could be half of that, or there could be no deductible. So the second stage it's called your initial coverage limit. And it's just essentially from the deductible up to $2,000. And then stage 3 is catastrophic. It's $2,000 plus. After that, you don't pay anything additional for your medications. Now, the way that they calculate up to that what is that $2,000 is a little bit different, and it's a little tricky. So I'm going to go over it pretty high level. For this example, we're looking at a tier 3 medication, so that's a brand name. The retail cost of it is $1,000. Your copay for that medication, for that tier 3 for a 1 month supply, is $45. And then for this example, your plan doesn't have a deductible. So you either pay the copay or 25% of, so you get credit for, my apologies. You get credit for either the total sum of your copays or 25% of the retail cost of the medication. So in this example, 25% of $1,000 is $250. Your copay is $45, so you're going to get credit for that $250. Meanwhile, you're paying $45. Now, once that combination, if it's the total sum of your copays or 25% of the medication, retail cost of the medication, once that number hits $2,000, then you don't pay anything additionally for your medications for the rest of the year. So for this, with 25% being of $1,000 being $250, you would get credit for $250 for 8 months. Now that's when that number hits $2,000. Meanwhile, you've only paid $45. Let me start that over. Sorry, I got a call. So 25% of $1,000 is $250. So you'll get credit for $250 for 8 months up until that number hits $2,000. Meanwhile, you've only paid $45 a month. So that's how this works. Now, it's a little bit different if you have generic medications or if the plan has a deductible, but I feel like this is a really good overall example just of how it works a little bit. You don't need to know every little minute detail. Don't worry, the carriers will keep track of it for you. Now, for those who do have a deductible, you're still going to have a really high cost up front. So a new program that Medicare, that CMS has rolled out, is called the Medicare Prescription Payment Plan, or M3P. So if you have a deductible that you have to pay, let's say your first fill is $500, and then after that it drops because you've gone through your deductible. You can elect to join this program, so it's 100% voluntary. The carrier this would be after enrollment. So the carrier would estimate, okay, this is how much your medications would cost for the entire year. And then if we're starting at the beginning of the year, January, you divide the total cost by 12, and then that's your monthly payment. So whenever you go to the pharmacy to pick up the medications, you don't pay anything. You pay the carrier directly. Now, if you're starting this in the middle of the year, they take into account what you've already paid for your prescriptions. Let's say you just switched plans mid-year. They would take into account what you've paid for your medications on your old plan, and then subtract that from the $2,000, and then divide that by however many months are left, and that's how they get your number. Now, what is really cool about this, and you might be saying, oh, well, Mackenzie, how can anything be cool about Medicare prescription drugs or spending money? But I think it's really cool, is that any money that you put toward your medications rolls over from plan to plan. So you don't start over if you enroll into a new plan. You don't start over at zero. You start right where you pick up right where you left off. And so just to kind of give you some additional reassurance there, but I think that's pretty cool. Now, are you eligible? So you have to have Part A and Part B, and then you must permanently reside in a planned service area. Now, if you have a physical address and then a mailing address that are in two separate counties, which I encounter quite a bit, you have to use your residential address to qualify for the plan. You can still get mail at your PO box or the other address, but it's your permanent physical address that dictates what plans you are eligible for. And of course, if you have a chronic condition such as diabetes, cardiovascular, or congestive heart failure, or you have Medicare and Medicaid, there are different eligibility requirements for that. So when can you enroll? So when you first turn 65, you have a 7-month initial enrollment period. We call it IEP. During this time, it's the 3 months before the month that you turn 65 and 3 months after that. So if your birthday is in April, you can enroll starting January 1st. But remember, you have to have that Part A and Part B first. But if you enroll January to March 30th, then everything will start on April 1st. If you apply in April, it'll be effective the 1st of the next month. So it'll go like that for each month until the end of the 7th month. So the last date that it could start would be in the 1st of the 8th month. After that, you have to wait for another enrollment period. Now, if you're still working, then you have a longer time. So yes, you still have the 7-month enrollment period, but your special enrollment period, you can sign up any time before your coverage ends, and then you have an additional 2 months to sign up for it after that. And so you don't have to, if you're in that situation, just reach out to me, because there's some additional forms that you would need. Now, every year we have the annual enrollment period, AEP. It's from October 15th through December 7th, in which you can make changes to your plans, Medicare Advantage prescription drug plans. Any changes made during that period will start on January 1st. Now, we don't have the benefits for 2026 or for the next year yet. We are able to share them, and we have the full benefits on October 1st. So if you have any questions about, what's it going to look like next year, we won't be able to compliantly answer your question or just answer it at all, because we won't have an idea of it. Now, after the AEP, the annual enrollment period, there is another one. So it's called the Medicare Advantage Open Enrollment Period. With this one, we are not allowed to market this, but just know that there is a time period after that. So it's January 1st to March 31st. In order to make a change here, you have to have an existing Medicare Advantage plan. So you can either go to another Advantage plan, or you can disenroll from your Advantage plan, enroll in a drug plan, and then you can get a supplement. Now, we'll talk about supplements next time, but I just want you guys to know, take a deep breath, that there are multiple time periods in which you can enroll. So if you have questions about that, about this or anything, just please reach out. Mackenzie Anderson, that's my phone number right there, 512-599-9527. You can send me an email, Mackenzie@premiermedicaresolutions.com. And that is my physical address. I have an office in Cedar Park. So just give me a call. Also, don't forget to email me or call me, text me if there's a topic that you want me to cover that I haven't covered so far. So anyway, until next time. Thanks for listening to another episode of the Medicare Matters podcast with Mackenzie. Please make sure to subscribe wherever you get your podcasts so you don't miss an episode. Please also leave a review, as that helps me reach more people that can benefit from this podcast content. If you have questions or topics that you want me to cover for a future episode, please email them to Mackenzie@premiermedicaresolutions.com.